Good morning, everyone. This is Tim Henry from Cincinnati. Wishing that I was with you all in Scottsdale. But my goal today is to talk about complete revascularization in STEMI and where we are in 2020. So first of all, this is a common problem. So when you look at STEMI overall, 40 to 65% of patients will have disease in a non-culprit vessel of more than 50%. And we know they have a worse clinical outcome. Question is, when you intervene, is it based on data? What data? How do you decide? And so what I'm going to do is spend some time today walking through, because I think it's a really interesting story about why clinical trials are important and the nuances of those clinical trials. So if you look back, this is actually data from the early 2000s. Clearly, if you had triple vessel disease, your mortality was 7.8%, double 4.4, single vessel 3.2. And if you look at a second trial that came later in 2014, two important things. Clearly still with non-infarct vessel, you had higher mortality, but notice that the overall mortality was cut almost in half. And with non-infarct artery disease, it was less than 2% at day 30. So you can see two things. Number one, multi-vessel disease is higher risk, but number two, our overall outcomes with STEMI have been getting better overall. Another problem with this is there's considerable heterogeneity. So if you see on the left side of the scan, an occluded LED with a moderate lesion in the RCA, that's one patient. On the right is a patient with an occluded RCA with a subtotal mid-LED. Well, and the nuances of this are very big, as everyone knows, if it's a diagonal or an OM. So the issue is, even though multivessel disease is common, there's considerable differences in the patient population, which makes it difficult to look at. So what did the guidelines used to say? So this is a fascinating look at this. If you look back in 2011, 2012, 2014, basically guidelines as well as AUC said this, that PCI should not be performed in a non-infarct artery at the time of primary PCI in patients without hemodynamic compromise. In other words, it was class 3, it would do harm. And interestingly enough, at the time, STEMI and cardiogenic shock in multivessel disease was actually class 1. And what we've done from this in really 5 years, we've completely flipped those. And let's look at how that happened. So this was don't do it, but was it really that simple? Well, it turns out it wasn't. And I think part of the issue is this. There's lots of options. Do you do infarct artery only? Do you do multivessel PCI or so-called preventive PCI, which comes from the PROMI study? And if you do you do it in the same procedure with or without FFR? In hospital or with a stress test or out of hospital with a stress test. So there was a lot of questions and there's a lot of nuances. So we're going to briefly touch on those, and then I think spend most of our time on the complete trial, which is a very important new study since a year ago. So first of all, I'm not going to go through many non-randomized trials, but I just want to show you where this all started. So this is actually from Mid-America Heart Institute. This was their one of the first large sites to do primary PCI, as you know. They had 500 patients had multivessel disease, and they looked at, these are all operator choice. And when they looked at this, they found that one of the predictors of poor outcomes was multivessel disease. And in particular, if you did it at the same procedure, and there was higher in-hospital mortality in this observational study. But when you look closely at the data, you'll find that everything else was worse in the culprit only group. So reinfarction in 30 days, at 1 year, target vessel revascularization, overall MACE, everything was worse. So there was some mixed, even in this initial one. And of course, there was a reason why those patients underwent it. So this is what had led to the harm and don't do it. Well, then there was a whole series of randomized trials that we'll touch on, a couple important ones, followed by a meta-analysis that we'll just do briefly. First was the PRAMI trial, relatively small trial, published in the New England Journal, which showed that if you do complete revascularization of any lesion greater than 70%, that you would see there was the primary outcome, and the study was actually stopped early because doing complete revascularization was better than doing culprit vessel only. This was followed by the culprit. Now, importantly for the PRAMI trial, all of these were done in the single procedure. In contrast, in the culprit trial, it showed the same thing. Complete revascularization was better. That culprit-only artery had higher event rates than the primary endpoint. This was actually maintained at 12 months. The difference with culprit is this was fixing complete revascularization in hospital. It may have been in the first procedure, or it may be staged several days later. So, but again, these trials, and if you look at the meta-analysis that looked at a whole series of trials, what it showed you that the tide had turned, and it was now looking like complete revascularization was a more important thing, which brings us really to the complete trial. And I think it's really instructive to look at the series and how this has changed over the last 20 years. And I think really Dr. Mehta and colleagues and really everyone in the complete trial should really deserves important congratulations. Number one, for the patients to actually get power the trial adequately, to get a large number of patients in the trial, and to maintain long-term follow-up. So this is, I think, one of the most important trials from my perspective, certainly in the last year, but in the last 5 years. So the trial was published in the New England Journal, and the background is, as I show, should we routinely revascularize them, or should we manage them conservatively? The previous randomized trials had suggested that PCI reduces revascularization, but none were completely powered. And likewise, the meta-analysis were supportive, as I showed you. So this was the primary hypothesis to determine whether a strategy of routine staged non-culprit PCI with the goal of complete revascularization is superior to a strategy of culprit-only PCI in reducing the composite of CV death or new MI. This is the trial design here. You can see there was over 2,000 patients in each group. And the patients, another really important thing, the patients were treated with guideline-directed medical therapy. Ticagrelor was strongly recommended. And the follow-up, the median follow-up was for 3 years, and you'll show Kaplan-Meier's out to 5 years. And the primary endpoint was a composite of CV death or new MI, and CV death, new MI, and ischemia-driven revascularization. You can see there was global recruitment, but 1,700 patients in North America, so a large presence there, as well as 1,900 in Europe. Baseline characteristics kind of tell us about STEMI in 2020. So 70% had less than 6 hours onset to culprit PCI. The discharge of medications, these patients were incredibly well treated. 99% aspirin, 99% P2Y12. The majority of that was ticagrelor, 98% statins, 85% ACE inhibitors, 88% beta blockers. So that's important, and we'll come back. You also note that about 20% of the patients had diabetes, only 7% had previous MI, and still about 40% were current smokers. So this is what these are the patients who have STEMI in 2020. If you look, 91% were primary PCI. There was some pharmacoinvasive and some rescue. 80% were done radially. Most of the patients who had non-culprit vessels, 76% were one, but there were some that had multiple. If you look at the distribution of MIs, it was standard and what you would think. And there was 2 ways you could get in. Either you had a visual stenosis greater than 70%, which occurred in the majority of the patients, or you had a lesion 50 to 69% with an abnormal FFR. But you'll note that that did not occur very frequently. The majority were visual greater than 70%, as you can see there. Complete revascularization was achieved in that arm in 90% with a final syntax score of 0. So this was an excellent trial. It accomplished what it set out to do. And what you saw is that the co-primary endpoint showed a significant reduction in death or new MI. And this is important because you can see the curves continue to split as you go out through time. The number median entry was 37, highly statistically significant. But look also at this, death or new MI at 5 years in the complete revascularization arm was just above 5%, really about 7%, which is very low event rates. And likewise, if you look at death, new MI, or ischemic-driven revascularization, look again, is highly statistically significant. These curves separate even early, and you can see that in particular with complete revascularization at 5 years, those patients did extremely well with a combination of complete revascularization and excellent guideline-based medical therapy. Now, what about the timing? So complete tells us that we should do complete revascularization. Not so sure yet about the timing. And this is the data, and there's more to learn, but basically if it was done during the initial hospitalization, there was benefit. Likewise, if it was done within the first 23 days, there was benefit. So I can't still tell you whether it's better to do it in the same procedure, in the same hospitalization, or discharge the patient and do it within the first 23 days. We know complete revascularization is better, but it looked in both of these that the timing was, you could do it either. And so I think it still needs to be a judgment as you take care of these patients. So this is the final results. You can see in terms of the second co-primary endpoint, the number needed to treat was only 13 patients. So from my perspective, this is now conclusive. We should do complete revascularization. And the issue is still the timing, and we can talk more about that. Now, what about if you have cardiogenic shock? So that excluded patients with cardiogenic shock. And I'm just going to spend a couple minutes to remind you about the culprit shock trial. First of all, multivessel PCIs, multivessel CAD is even more common, that this is about 75% when you have cardiogenic shock. And the culprit shock trial, remember this prior had been a class 1 indication to do multivessel PCI. But the culprit shock trial actually showed the opposite, that multivessel PCI, the primary endpoint was worse with more increase in mortality or renal replacement. And in fact, there was an increase in mortality at day 30. Now, when you follow that, so that led to a change in the guidelines from 2A to actually 3B. So again, we've completely switched this with PCI and STEMI. But when you look at 1 year, you can see that the complete revascularization actually, it was still significant. So the landmark analysis showed no differences in terms of the primary endpoint after the initial 30 days. But in fact, there was less repeat revascularization in the multivessel arm. So that, again, I think it's a little bit complicated. And then the final point about culprit shock is this. When you look at the death, there's no difference in sudden death. There's no difference in recurrent MI. So where were the excess in death? Well, interestingly enough, there was twice as many brain deaths in the multivessel PCI. And an important issue with the culprit shock trial was that 50% of these patients had a combination of cardiogenic shock and cardiac arrest. Now, is this because there was harm? Took a longer time to hypothermia? We don't know the answer to that. But I will say that when you look at cardiogenic shock trials, it's a very important point that there's a very important interaction between cardiac arrest and cardiogenic shock. So that if you have both, you have a mortality of about 47%. While if you have just cardiogenic shock, it's about 25%. So one confounder with the culprit shock trial that we'll need to sort out is what's the effect of cardiac arrest, and what would have happened if this would have been only cardiogenic shock alone trials. So in summary, this is a common clinical problem. It is a heterogeneous group of patients. Many of the initial studies were small, non-randomized, and old. The previous randomized were small, came to some different conclusions. Meta-analysis came to different conclusions. So then we have this new era of randomized trials, PRAMI, culprit, DYNAMI, compare all that supported multivessel PCI. And then I think the complete trial, a very important trial, supports multivessel PCI without shock, but still some unanswered question. What about the timing? Do you need FFR? And what do you need to show ischemia? So those are still a little bit unanswered. And then finally, the culprit shock trial raises major questions about multivessel PCI with shock. I don't know that we can say never do it, but I think you have to think twice about doing it. And clearly, we need more and larger trials to confirm this result. And there's still, finally, there's challenges. Reimbursement is still complicated. There's issues about AUC. Do you need ischemia testing? And then in the era of COVID, it's even confused it more. Do you do multivessel PCI? Some people favor doing it and letting patients go home. Some people favor just doing the culprit only. So, and again, we probably have no data to support that. So very interesting topic. I think it's shown us a lot about the importance of clinical trials. And clearly, it's our thinking has evolved over the last 20 years. So appreciate the opportunity. It's much clearer than it used to be, but I'm not sure if it's still completely done. And importantly, my last point is, you still need judgment. What's the risk territory? What's the patient's creatinine? What's the outcome of the PCI of the culprit vessel? And those are key things to help determine your strategy. All right, again, I wish I was with you all in Scottsdale, but hopefully next year. And thanks for letting me be here today. Thank you very much.